Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Paul Coppo in Paris, France, and Professor Paul Brinkkötter in Cologne, Germany, for an update on the treatment of thrombotic, thrombocytopenic purpura, TTP, focusing upon the Mayari study on plasmapheresis-free TTP treatment. Dear Paul and Paul, we're happy to host the two of you for our 2026 update on TTP after our 2025 webinar in German language with, again, Paul Brinkkötter and Paul Knöbel. So apparently everybody in TTP is called Paul. Thanks so much for joining us.
Thank you for having us.
Professor Dr. Paul Brinkkötter is Deputy Director of the Second Department of Internal Medicine at the University Hospital in Cologne, as well as Professor of Medicine for Glomerular Research at the University of Cologne. His research focuses on thrombotic microangiopathies, and he's the organizer of the annual TMA Symposium in Cologne, as well as a very frequent guest on Marcus at Home whenever we talk about TMAs. Professor Paul Coppo is Professor of Haematology at Sorbonne University in Paris. He heads the French Reference Center for TMAs called CNR-MAT, which is a resource center for the diagnosis and the management of TMAs. He's also head of the Department of Lymphoid Malignancies in Saint-Antoine Hospital, which is involved in the management of rare lymphoid malignancies and other immunohematological diseases. Thank you both for coming.
Thank you very much for the invitation, and I'm happy to set the scene for the Mayari study. And before I start, I would like to declare my potential conflicts of interest. And then I will jump into my key objectives. So in the beginning, I will briefly summarize the evolution of iTTP and what we consider the standard of care. And then discuss initial thoughts, how to manage iTTP without plasma exchange is actually not that new. And then, of course, I will highlight some data after the introduction of Caplacizumab and its impact on PEX-free management. So when we talk about TTP, I have to at least once mention Eli Moshkowitz. It's more than 100 years now since he first described this clinical syndrome, this pattern of injury consisting of profound thrombocytopenia, microangiopathic hemolytic anemia, and multi-organ failure. And this combination, which we acknowledge as thrombotic microangiopathies, when we talk about TTP, comes along with severe ADAMTS13 deficiency. And here we can distinguish two distinct entities. On the one hand, congenital TTP, or the Upsher-Schulman syndrome. It's a ultra-rare disease, around about 50 to 60% present during early childhood, and we have another peak during pregnancy. And the second, by far the more common form, the immune-mediated TTP, where we have autoantibodies. So in both cases, the root cause is the deficiency in ADAMTS13 activity. Let it be congenital, or let there be antibodies directed against the metalloprotease ADAMTS13, and thereby inhibiting its function and resulting in microthrombi formation in our smallest vessels. It can affect any organ system, and as shown in this cartoon, we have platelet-rich microthrombi and schistocytes, and these are the typical features of TTP. When we talk about therapy, we have to go back a few years. In 1991, Gail Rock, together with the colleagues from the Canadian apheresis study group, published their landmark paper on the use of plasma exchange. And they convincingly showed and reported almost 100 cases where they treated patients with plasma exchange, and that they reported that the outcome was significantly superior to plasma infusions alone. And since this time, plasma exchange has been the backbone of our treatment strategies when we treat patients with TTP, or when we consider to be TTP the differential diagnosis. And since then, survival rates have significantly improved. Untreated TTP to this day is a lethal disease with survival less than 10%. However, with modern treatment protocols, it's now almost a curable disease, and we reach survival rates over 95, almost 100%. And the backbone is not only plasma exchange, it's nowadays the combination of plasma exchange to remove antibodies and to replace ADAMTS13. It's the combination of plasma exchange with broad immunosuppression, steroids, and rituximab to suppress the inappropriate immune response. And since a few years, we have the nanobody Caplacizumab available in most countries that inhibits the binding of thrombocytes to ultra-large Von-Willebrand multimeres and thereby limits the microthrombi formation. And it has been shown to reduce exacerbation rates, and patients usually recover within 2 to 3 days. So this is the current standard of therapy. And the question is why to change this winning formula? What to achieve and what are the thoughts? Why should we consider changing? And there are actually quite a few clinical scenarios where we have to omit therapeutic plasma exchange, either because of the refusal of blood products, for example, out of religious beliefs, because of severe allergic reactions to plasma, the patient's preference, or the inability to place a central line, or problematics or difficulties in the logistics in providing plasma exchange to our patients. And I now, summarize a few aspects that will cover these scenarios. So first, I want to talk about what's called the Jehovah's Witness experience. It goes back more than 10 years, and it's the work primarily from James George from the United States. And in 2017, he published a small case series comprising 4 patients that were treated without therapeutic plasma exchange. And I must say, successfully treated. All of these patients were Jehovah's Witness, and they refused the transfusion of blood products. And this actually forced the treating physicians to change the treatment algorithm. And you can see they used high-dose glucocorticoids, they used various immunosuppressive drugs to control the disease activity and to save the patient's life. And in the discussion of this case series, the authors already discussed the new drugs that were tested at that time. And this was Caplacizumab on the one hand, the nanobody that blocks von Willebrand thrombocyte interaction, and they also discussed the use of recombinant ADAMTS13. And they come to the conclusion that in the future, with these new drugs, there might be a possibility that plasma exchange may not be an essential treatment of TTT in the future. So this dates back to 2017, so almost 8 years or 10 years. And this is where we are at the moment. And before we do discuss, first clinical evidence, I would like to also discuss plasma exchange by itself and what can be achieved by plasma exchange and what can be expected and what cannot be achieved. And I think this is actually quite important to not only know the benefits, but also the limitations of this procedure. So the idea is to remove soluble factors and to, in this case, for example, we work with separating membranes that separate the cellular components of the blood from the fluid phase. And if we do so, it becomes clear that we highly rely on a high intravascular distribution of the solvents of choice that should be removed. And for immunoglobulins, as you can see here, the percentage that actually can be found in the intravascular compartment varies quite a bit from 45 to 75%. So not all immunoglobulins are circulating in the bloodstream, explaining why with plasma exchange, we will never remove immunoglobulins to 0. There is a saturation, and this is around about 20% of the initial concentration. So it's there's a limit to what extent plasma exchange may help us to reduce the antibody load. And this actually holds true for the different methodologies that are available. So this holds true for membrane separation, but also for centrifugation-based therapeutic plasma exchange. There's actually no difference between the two methods. And of course, there are adverse reactions to therapeutic plasma exchange. And there are different reports on this. So this is just one example out of the Oklahoma TTP registry, comprising patients from 95 to 2015. And you see high numbers of complications. 3 out of 78 patients actually died of complications from therapeutic plasma exchange. They reported 18% had sepsis with documented bacteremia related to the central venous catheter and other complications. However, this is not the whole story. We have additional complications that may arise from therapeutic plasma exchange. We know about electrolyte disturbances, hypocalcemia, and metabolic alkalosis, for example, because of the presence of citrates, which is used as regional anticoagulation in patients with high risk of bleeding, such as TTP patients. And citrates is metabolized in the liver, produces bicarbonate and citric acid. And the accumulation of citrate may cause some toxicity, which is called citrate toxicity. So it's way complex. And we have the logistical part. Think about the COVID-19 pandemic, where we had limited resources, limited personnel and instruments available. And there were cases, and this is just one case report, emphasizing the situation where plasma exchange was not available in certain places, and patients had to be treated without plasma exchange. So it's not surprising that soon after the initial landmark paper, the Hercules trial, was published in the New England Journal, that was in January 2019, a few months later, the first report on plasma exchange-free treatment of TTP was published. And again, it was a patient from the Jehovah's Witness cohort that was treated with glucocorticoids, rituximab, and it's actually the first time that it was reported with Caplacizumab, but without plasma exchange. And you see the very positive course over the next days. And there were a few other reports thereafter from the United States, but also from Europe. So this work was done together with our colleagues in Austria, describing a few patients that were treated without therapeutic plasma exchange by the combination of immunosuppression, steroids and rituximab, and Caplacizumab. And actually, the largest cohort was published in 2024, again, a cooperation between our colleagues in Austria and our registry here in Germany. We put together 41 patients with 42 episodes, and we were able to compare them to patients from our registry that were treated first line with Caplacizumab, immunosuppression, and therapeutic plasma exchange. So in total, we report on 101 episodes, 42 without plasma exchange and 59 with plasma exchange. And in this retrospective cohort, the plasma exchange-free approach was not inferior as compared to the standard treatment cohort. It is important to mention that there was a significant difference in the patient selection with respect to the LDH. So in the plasma-free cohort, the LDH values were lower, significantly lower as compared to the standard of care group. However, when we stratified for LDH, we did not observe any differences between the groups. So again, this is the data that was out there before we started to think about a prospective study on this. And now I want to head over to you, Paul, to basically show us the Mayari data and to solve the question whether Mayari can solve all open questions. And the question is, are we talking about results? In German, we call it die kommen daher auf leisen Sohlen. I think in French, it's something like s'approcher à pas fautré or something like this. I hope you get it. My French is a little bit rusty. Or are we talking about the city in Cuba, or even about the Philippine mythology and the god of the moon, the hunt, the conquest, and beauty. So I hope you can tell us a lot about beauty. And with this, I think I head over to you, Paul, to sum up the Mayari data. Thank you very much for your attention.
So thank you, Paul, for your presentation. Thank you, Gunnar. Thank you, all the team for organizing this SIMPO and inviting me. So I'm really happy to present you the results of the Mayari trial that have been presented at the last ISTH meeting. And as you know, the German group was fully involved in this trial, and Paul and I are, let's say, driving with Sanofi the writing of the manuscript. So these are my disclosures. So I will be quick on this slide because Paul made a nice introduction. This is just to emphasize that immune-mediated TTP is, yes, a rare disease. So it may not be quite easily recognized in emergency from colleagues who are not, let's say, familiar with the disease. And as I always say in a caricatural way, those patients are the patients of the Friday evening. I mean that, as you know, those patients systematically arrive on our departments at somewhat extreme times of the day or of the week, typically the Friday evening, in the night, in the weekend, while the disease is spontaneously fatal. For that, just read again the papers of the 60s and 70s, such as the one I put in the reference at this time, where systematic plasma exchange was not yet the rule. Virtually all patients with iTTP died from their condition. And again, these patients are exposed to a certain risk of death until we start the treatment. So in this context, strategies aimed at alleviating the treatment are welcome. So this is the so far standard treatment of patients with iTTP. And again, as Paul mentioned, this strategy aims at addressing the three pathophysiological pillars of the disease, which includes the replenishment of ADAM13 levels to saturate the antibodies against ADAM13 and to cleave the VWF multimers. So to achieve this goal, you need to bring those patients very large volumes of plasma. So plasma exchange is the mainstay treatment, but it is burdensome, invasive, with significant morbidities. And as I said, it is not always readily available, especially when patients arrive in the night, in the weekend, and so on. The second strategy is immunosuppression with rituximab and steroids to reduce the production of antibodies against ADAM13. And then the third and the most recent strategy is the inhibition of platelet VWF interaction, and this is achieved with Caplacizumab. So Caplacizumab is a nanobody that has been derived from camelids, and it's composed of two heavy chain domains of antibody that recognize the A1 domain of VWF. So the two heavy chain domains are linked with an alanine linker. And by doing so, Caplacizumab is able to block the interaction between the A1 domain of VWF and the GP1B on platelets, allowing to block immediately the neoformation of microthrombi in this disease. So Caplacizumab has been evaluated on two international trials, and more recently, an international effort through the International Working Group on TTP reported more than 1,000 observations of patients treated with the triplet treatment, including plasma exchange, caplacizumab, and immunosuppression. And these are the most, let's say, key results of this study. And we could show in this study with a great amount of patients that caplacizumab allows to improve survival in these patients. This was not so obvious from the clinical trials because the number of patients was somewhat limited. So the power of this study was not high enough. But here, with more than 1,000 patients, we could really nicely show that, as you can see, survival is better with caplacizumab than without. Since with the use of caplacizumab, we can reach more than 98% of survival, so virtually all patients recover from the disease, versus 94% without caplacizumab. And we could state that the number of patients needed to treat to save one patient from TTP is 22. The other points are that exacerbation could be decreased by 8-fold with caplacizumab. This is, for me, the most impressive effect of caplacizumab. We can see that in these patients, platelets improve rapidly and durably. Worsenings of platelet count are now quite exceptional. And similarly, refractoriness also became quite exceptional. So we definitely obtained a faster clinical response with caplacizumab with less exacerbations and refractoriness. So in this context, the question is, could we consider a therapeutic de-escalation with PEX-free regimens in these patients? So the first clues came from the Jehovah's Witnesses who cannot be treated with plasma and who usually died from the disease until some teams started to treat them with caplacizumab. And the second clue came from the German and the Austrian groups who put together their patients and their experience in the treatment of patients without plasma exchange, but with only caplacizumab and immunosuppression. And this very first series, the team had reported 6 patients with 7 episodes who had a very good outcome, despite the fact that some of them were elderly patients and some had cerebral and or cardiac involvement. So these were very promising results that pushed this team to recruit still more patients. So Paul showed these results. And this is to show that from these 42 patients treated without plasma exchange, but only with caplacizumab and immunosuppression, the outcome was comparable to this of patients treated with a standard plasma exchange associated treatment. So again, here I also, as did Paul, emphasize that the 2 groups were more or less comparable, but still patients in the PEX-free cohorts were patients who had a frequent relapse of the disease. So which means that in these patients, adenosine activity was more easily anticipated, and it's likely that the diagnosis was made earlier than patients with the first episode of TTP. And probably that these patients also had a tighter follow-up. So again, relapses were probably more rapidly anticipated. And this is reflected by the fact that LDH level was a little bit less increased in the PEX-free group. Platelet count was a little bit less deep. And if I remember well, the neurological involvement was a little bit less frequent in those PEX-free patients. Nevertheless, as you can see, the time to platelet count recovery was exactly comparable with and without plasma exchange, and the authors observed no death and no refractoriness in this PEX-free regimen. So again, these results were very encouraging, and this put fuel to start a clinical trial, so the Mayari study. So the aim of the study was to explore caplacizumab as a potential first-line therapy with immunosuppression alone, based on those rationales. And Mayari is a phase 3 open-label, single-arm, multi-center trial to evaluate efficacy and safety of caplacizumab and immunosuppression without first-line plasma exchange for adults with immune-mediated TTP. So patients were recruited. They were treated up to 12 weeks with a daily caplacizumab and immunosuppression according to the time they needed to recover platelet count and Adams-13 activity. And this was followed by a 12-week period of follow-up. Importantly, patients experiencing a lack of response to this alleviated treatment were allowed, of course, to have plasma exchange in emergency until recovery in association with caplacizumab and immunosuppression. So key inclusion criteria were adult patients with features of TTP. So a clinical picture of thrombotic microangiopathy, no underlying associated condition that could be involved in the prognosis and in the cytopenias, and patient had to have a French score of 1 or 2, so a mild renal involvement and a severe thrombocytopenia to rule out patients with other TMAs, especially the hemolytic uremic syndrome. Patients could have an initial TTP episode or recurrence, and Adams-13 activity had to be available within 2 days to demonstrate the diagnosis of TTP. Regarding key exclusion criteria, you need to have in mind that in this very first trial attempting to alleviate the regimen of treatment in these patients with a severe disease, we cautiously excluded patients with a severe presentation of TTP. I mean that patients with severe neurological or cardiac disease were not included here. So patients with coma, seizure, Glasgow Coma Scale below 8, stroke, and high troponin level were not included. And we also excluded, of course, congenital TTP, patients with contraindication to caplacizumab, and patients with another cause of cytopenia than the TMA itself. The primary endpoint was the proportion of patients achieving remission without requiring plasma exchange, and the secondary endpoints were the proportion of patients achieving remission irrespective of plasma exchange administration, and the number of patients who in the end required plasma exchange as a salvage therapy. The proportion of patients achieving clinical response, so the platelet count recovery, and the time to platelet count recovery. The proportion of patients experiencing an unfavorable outcome, including refractoriness, exacerbation, and death related to TTP, and adverse events. So 58 patients were screened, 46 were treated according to the protocol, and 40 of these patients completed the intervention period per protocol, while 6 did not, because 3 patients had an adverse event that required to stop caplacizumab. 1 patient withdrew his consent, and for 2 patients, this was the investigator decision. So these are the baseline characteristics of the 46 patients. Median age was 46. There was a predominance of females as expected. 6.5% of patients were elderly patients with more than 65 years old. Thrombocytopenia was profound. Adams-13 activity was below 10% in all patients, and as expected and as per protocol inclusion criteria, you can see that troponin level was normal within 84% of patients, because again, we excluded those patients with severe cardiac involvement. And similarly, the Glasgow Coma Scale was normal in, or almost normal in all patients. There was a good balance, 50-50, between those patients with an initial episode or recurrence. 7 patients had been already exposed to caplacizumab, and virtually all patients had concomitant rituximab in their treatment. So this is the important slide that shows the primary endpoint, so the remission without plasma exchange and irrespective of plasma exchange. So you can see that 43 patients out of 46, so 93.5%, achieved remission without plasma exchange, while 3 patients did not. So in those 3 patients, 2 needed salvage plasma exchange because they experienced an exacerbation while they were under Caplacizumab. And in these patients, Adamson activity was still depressed during the treatment period. And these exacerbations occurred at day 15 and 17. 1 patient presented with an herpes virus infection and achieved remission after starting plasma exchange. And in the second, he recovered platelet count with a plasma exchange, but he withdrew his consent from the study before the end of treatment, so he was unevaluable in the end. And the third patient actually was unevaluable because he had a chronic thrombocytopenia, and the investigators were not aware about this previous thrombocytopenia. So he could not recover platelet count while he responded to Caplacizumab and immunosuppression as he recovered Adamson activity. So this patient clearly responded to the treatment, but as per protocol criteria, he could not be considered as a responder because, again, he could not completely normalize platelet count. This is also an interesting endpoint, the time to platelet count recovery, and you can see that the median time to platelet count response was 4 days, and more than 75% of the patients achieved platelet count within 5 days after the initial Caplacizumab dose. Regarding the other secondary endpoints, so 45 out of 46 patients, so almost 98% of patients achieved a clinical response. So this means all patients but 1, again, who had a chronic thrombocytopenia and who could not be evaluated. So importantly here, keep in mind that there was no refractoriness to this treatment, no exacerbation post-treatment, and no death related to TTP. Regarding safety, we had no warnings, and the adverse events were those expected under Caplacizumab. So again, we had 3 patients who had an adverse events related to Caplacizumab that led to the drug discontinuation. 24 patients had adverse events related to Caplacizumab, and 1 had a severe adverse event related to Capla because he needed to be hospitalized for bleeding, but in the end, the outcome was favorable. And we had no severe adverse event that led to death or bleeding into a critical organ or life-threatening bleeding. So in conclusion of this trial, it demonstrated that Caplacizumab and immunosuppression without first-line plasma exchange is safe and effective for more than 95% of patients with iTTP without severe presentation. And this is an important point. So this first formal trial opens a serious perspective for a decrease in the burden of care in iTTP. And the key messages are that a majority of patients demonstrated a rapid platelet count response with a median time of 4 days following treatment initiation. Among the 46 patients, only 2 required plasma exchange due to a worsening of thrombocytopenia, and they did reach a clinical response. The safety profile of this combination is acceptable with no new safety concerns, but the main study limitation, and this is important to have in mind, is that we treated here, as with the German-Austrian experience, patients with standard prognosis, and those with a severe presentation were excluded. So one of the perspectives of this work is to now evaluate how we could treat with such kind of regimen patients with, let's say, a more severe disease. And this will be the next step of the story in the next years. And this is to thank all the persons who contributed to this wonderful trial, all the participating countries, the investigators, the co-investigators, the patients, the families, the givers, Sanofi for sponsoring the trial. And I want to add that this trial, as well as the recent work I talked about, Capla 1000, are two works that illustrate the power we have when we put our efforts together to work on rare diseases. Thank you for your attention.
Thank you so much for presenting the Mayari study and also these very interesting results. So we now have a couple of questions for both of you. Professor Coppo, you presented the key inclusion and exclusion criteria. So how do these criteria that you use for Mayari reflect real-world iTTP populations?
Excellent question. This is the key question indeed, because the results are presented here are results from a protocol. So as usual, we now need real-world experience data, and this will include less selected patients, which includes patients from less experienced teams, patients with as I said, more, let's say, serious clinical presentations, and this will be the next step. So I'm very cautious about the message, and indeed, clinicians have to keep in mind that these results reflect the efficacy of an alleviated treatment in selected patients, which includes patients managed by experienced teams, where Caplacizumab was easily available, where the diagnosis of TTP was made rapidly, especially because half of the patients had a known history of TTP, so it was easy to anticipate Adam's activity. So outside this context, we have to be familiar with the assessment in emergency of TTP diagnosis with the French score. And we also need to have we have to be familiar with the assessment of the severity of patients with TTP. So we need to assess rapidly how a patient is severe and should he treated with such regimen or not. So definitely we need more data, more experience in the future, especially now for those patients with a more severe condition.
So in clinical practice, when you see now a patient in your reference center in Paris, in Cologne, who would not meet the inclusion criteria, and I guess the most important exclusion criteria has been the severe neurological comorbidities, would you then decide on a individual base, or would you for these patients still go with plasma exchange? And maybe one additional question, if I got you right, people were not included if they had elevated creatinine and platelets above 30, but if platelets were below 30, they could be included even with severe AKI. Did I get that right?
Oh, just to clarify the inclusion criteria. So there was one exclusion criteria to rule out patients with HOS. So indeed, we ruled out patients with severe renal involvement to be sure that we would not recruit patients with HOS. So I agree that probably among these patients, we may have excluded patients with a very severe TTP and a severe renal involvement. But still, it's likely that, at least in our experience, those patients are quite rare. We also excluded those severe patients with cardiac and neurological involvement. And in our center, in the centers, including the reference center, we at this time treat the most severe patients with plasma exchange and the rest of the treatment. We are thinking about, as others, to treat those patients with a combination of recombinant adenosine, Caplacizumab, and immunosuppression, with the aim to get rid definitely of plasmapheresis and plasma. So here we are.
I fully agree, but I think it's in real life, it's, as always, more complicated. Because the question is, how do you define severe neurological involvement? What do you have in mind? Do you have in mind a patient with stroke-like symptoms that is comatose? Or do you have in mind a patient that is complaining about severe headaches, for example, or that has aphasia, or had a syncope, or, symptoms that are, severe, but not as severe as, for example, severe stroke-like symptoms with hemiplegia or, other symptoms. So, for example, we had one case here in Cologne, a patient who was bilingual, Polish-German. And when she entered into the emergency department, the first thing she received was an MRI and a CT scan from her brain, because initially it was it's a stroke. It then turned out to be TTP, and she received her first dose of Caplacizumab in the emergency department. And by the time she was transferred to the emergency unit, this took 4 hours. From the emergency unit to the intensive care unit, this took 4 hours. With full, support. By the time she arrived on the ward, she started to speak German again. So we were, in a situation where we had to answer, so what else do we want to gain by now adding plasma exchange to our treatment protocol? I think by definition, she was severely affected, but she responded very well, clinically, and also when we tested her platelet count. So we were 100% sure that the diagnosis was right, she was responding. So we decided to watch and wait her clinical response and the hematological response during the next hours. And in the end, we omitted plasma exchange in this, very, very specific case. This would have never made it into the Mayari trial. So I think it's a very, very individual decision that we have to make, and it's very important to monitor the individual response to the treatment. Because I think it's very easy when the diagnosis has been made, right? If you have a patient with a known history of TTP, it's easy to make the diagnosis. But in most cases, we are not that sure initially. And in most places, we do not have ADAMTS13 activity testing available 24/7. So there is a certain level of uncertainty. But we have to start to treat our patients. And now I think the question is, should we then do plasma exchange, or should we rather start with Caplacizumab, assess the patient and the response, and then decide whether it's necessary to increase the treatment and start plasma exchange a few hours later?
Yeah, I agree as well, Paul. That we chose cautiously to exclude the most severe patients, but as you mentioned, it was an empirical decision, and maybe that the most severe patients will respond as well as those who have a less severe presentation. This was an empirical decision, just for caution. But maybe we could say that maybe it was useless.
No. And I think for clinical study it was absolutely right. But I think in the future we should put all our efforts into rapid testing and availability of the drug. So whenever we make the diagnosis, we can immediately administer Caplacizumab. It will always take a few hours to organize plasma exchange, to get the team ready and everything. And we have to use the time for the drug to do its job.
Sure, of course.
I think that's a great implication of the Mayari study for this early diagnosis and rapid initiation. How do these findings that you made in the Mayari study inform updates on international guidelines? Do you believe it's enough data? What would you need in order to make some changes in these very old guidelines that we have that you presented?
We have 2 updates seen this year. So we have an update from the ISTH guideline. I think, Paul, you were part of this, right? And their plasma exchange-free management was not discussed, as far as I remember. Please correct me. We have a new German guideline that was published a few weeks ago, there we already discuss this issue and say, well, in the future there might be, an option, and there are certain centers where, in individual cases, this might be an option. So I think we will make progress. It will take some time. And as always, guidelines rely on published evidence. And to generate this evidence, it does require time. It does require that we keep on working together on a global level to put our cases together and then publish on it.
Yes, indeed. We probably need some more real-world evidence with this strategy. We need to better define what we consider as severe patients who would still need the complete treatment. And again, we probably need to go through a step-by-step process, as I always say, to avoid spoiling the party. I mean that you need to perform this regimen formally on experienced centers who have rapid access to Caplacizumab, who are familiar with the diagnosis of TTP among other forms of TMA, and where you have an intensive care unit available in any case. So this means a kind of organization to be sure that you do not lose chances to the patient.
And I think this is a very important point. In France, in Germany, we are in the very lucky situation that we have the drug available, we have the testing available, and if not at our site, we will get it within a few hours or 1 or 2 days at the latest. But this is not the standard throughout the world, not even in Europe. And there are countries where testing is an issue. So, for example, think about Harvard Medical School, the famous hospital in the world. They have to send their sample to Wisconsin to get ADAMTS13 activity results reported back. So we are in a very fortunate situation in Central Europe. But if you think about international guidelines, they have to reflect the whole world, which is another aspect that has to be considered when we talk about the guidelines and what the guidelines reflect. So I think we should break it down to best practice guidelines, national recommendations, because they best reflect the situation that we face on our in our daily work.
I would have, from my part, 2 final questions. So the first, to the study design again. If I got it right, the 3 studies, so Mayari, Titan, and Hercules, used a somewhat different regime of the drug, and the length of the treatment was somewhat different. Surely it's a matter of cost, but if you stop too early, you may not have a successful treatment. And if I got it right, that's vice versa, the risk if you treat too long, that the recovery of ADAMTS13 might be somewhat prolonged. I found some hints on that. And the other question would be, do you believe that in the not too far future, recombinant ADAMTS13 may enter the stage here for these people, or will this remain to congenital TTP?
Okay, so I may start first. So the duration of treatment with Caplacizumab indeed changed from one trial to the other. First, in Titan, we treated patients for 4 weeks following the last plasma exchange session, but we observed that parts of the patients after this 4 weeks treatment remained with a severe ADAMTS13 deficiency, and the stop of Caplacizumab led to a relapse of the disease. So this is why in Hercules, we allowed patients to be treated 1 to 4 additional weeks after the 4 weeks period with Caplacizumab. So in total, 4 to 8 weeks if needed, depending on ADAMTS13 activity outcome. So this is one point. The other point is that it's likely that PEX-free regimens do not, as opposed to what has been published, do not impact the time to ADAMTS13 improvement. So it's likely that the time to ADAMTS13 improvement may not change so much from the ancient trials to Mayari and the future ones. And regarding recombinant adenosine, of course, if I understood well your question, the recombinant protein may be another tool to treat those patients. And the $1 million question for the future is to know whether we should treat these patients with Capla or with recombinant adenosine or with both if they are severe, or simply according to the underlying comorbidities or context of the patient.
Thank you so much. With this, I think we may conclude today's episode. Congratulations once again to both of you on this study and these positive results. Thank you for being on Markers at Home again for Professor Brinkkötter. And we're looking forward to hearing even more of your work and maybe being back again on Markers at Home.
Thank you very much.
Pleasure. Thank you.